So we've been asked to close at 4:30, but gives us 15 minutes for discussion. I'm sure there are a number of questions and comments that people would like to make.
Hello, my name is Susan Slaughter. I'm from the University of Alberta, Faculty of Nursing. And I'd like to pick up on the comment of Dr. Hirdes right at the end of his presentation, where it begins to become interesting between assessment of frailty and decisions about clinical intervention. And I know that Dr. Moorhouse also addressed that in her comments. Could you tell us more about what you think the use of the frailty scores are for clinical decision-making, please?
Do you want to start, Paige?
Thank you. Our philosophy with the PATH model has been that it is a really, as I said before, a really holistic understanding of a person's health that should guide care planning, and in particular, some of the nuances of their social circumstances, whether they're a caregiver for another person, the care that would be available for them should the outcome of an intervention be poor. So we spend an enormous amount of time getting to know our patients and not just them, but the circle of care around them in order to inform that decision. I think that that's what I speak of when I speak of care planning, is thinking about what decisions can we make today, and what decisions should we not make today, because I'm a firm believer that there are a number of limitations to advanced care planning, and the only thing worse than having no care plan is having a bad care plan. And we're starting to see the effects of some of the population-based interventions to try and get everyone to have a care plan without any information to inform that decision-making, or any checkpoints to understand whether the person making a care plan has a full understanding of their health or the cognitive capacity to be able to make those decisions. I think that these care planning decisions, when it comes to interventions and clinical decisions, are intensely personal. They are contingent on a very intense relationship between the provider and the patient and their circle of care, because if you're going to be making recommendations, those recommendations have to be highly individualized and contextualized within the limitations of what clinical practice guidelines or the evidence from the literature can tell us. These conversations take time. They should not be done by everybody. They require training, and they require a structure in order to be productive. So I think that the process is very complicated, and I think there's no shortcut. If there was, we would already be doing it.
John.
Maybe I'll just add a couple thoughts. I agree very much with what Paige had to say. I think one of the things that's an interesting challenge that I see in long-term care and home care and in mental health settings, which are the three where I do most of my work, is that when I started to become involved in inter-eye research, I sort of thought, okay, what we need to do is create some assessment standards that everybody can use, and everybody will know what to do with them, and things will be great. But what's interesting now is where we're at is I think we've done a pretty good job at getting these assessments in place, getting the data together. The data quality is pretty good, but I'm getting a bit surprised that at least some clinicians struggle with what to do with the results of it in terms of how to engage the person. So what we very much emphasize in the inter-eye group that I saw in Paige's talk, as well as the idea of collaborative decision making, of engaging the person in conversation. And the point of doing these assessments is to understand what's affecting this person's life, to give them some information to empower them, and then to have a conversation with them about what they want to do with it. So there's two sort of contrasting examples that I'll give you of what is probably not the right way to go with this. One, a story that came to us in very early days when we were implementing the home care instruments, and the staff that work on my team, the clinicians that do the education, know that learning, hearing these stories from frontline assessors are important as part of understanding the implementation process. So Nancy got a call from a home care case manager in one region who said, I've got an 85-year-old woman who looks like she's going to die in about 6 months, but she's drinking about 3/4 of a liter of Jack Daniels a day. She's triggered the alcohol use care planning protocol in the Rye Home Care. How am I going to get her to stop drinking? And the answer is you don't have to get her to stop drinking. You have a conversation with her, but if she wants to keep drinking, that's what she wants to do, that's fine. And you need to tell her a bit about risk, but that's her choice, but whether she stops drinking or not. The other example at the other end of the spectrum was one that caught us a bit by surprise. We have a new set of care planning protocols. They've been released for about 5 years. We're hoping that Ontario will start to move toward using them in nursing homes. And we've been asked to present to the Association of Resident Councils about what these new care planning protocols mean. And so we were stepping them through the logic behind them and how they could be used in clinical practice. And then my staff member Nancy asked the residents that were the nursing home residents on the Provincial Residents Council, about as high-powered a resident as you can get, have you had a discussion with your staff about your own care planning protocols? To a person, they said no. And when one of them went back to ask in the long-term care home to see her care planning protocols that had been triggered by her assessment, she was told, we can't give it to you, but we can give it to your power of attorney. So there's an awful lot of work that needs to be done, I think, in terms of working with clinicians on how to work with people. I wouldn't leave it to specialists. It should become a standard of practice for everybody.
Sean, any comments on that?
Probably a compromise between both here. I think I understand Paige's point, and I understand John's point as well, but I do think there is some specialized training that goes into these kinds of in-depth discussions, specifically when you're mapping out care plans specifically towards approaching the end of life. Often in the intensive care unit, everything is accelerated a little bit more, so these discussions occur under fairly traumatic, if not emotional distress at times. And even when we, as intensivists, interact with patients and their families on the ward, this is an acute care crisis that occurs, and I've heard both of you sort of use that term. Things are accelerated to a great extent again. I'm not sure everybody is, whether they're capable is one thing, but whether they're comfortable is another. And if you're not comfortable having those conversations, sitting down and taking the time, in particular at off hours, it may not be worth even having them to some extent. I think it's a duty that we should. However, I think it's a challenge for us as providers.
So we have time for 2 questions. The first person at the microphone, please.
Yes, Marilyn McDonald, School of Nursing, Dalhousie. My question's for Dr. Hirdes, but I'm happy for Dr. Moorhouse and Bagshaw to wade in as well. Given the reach and scope of the inter-RI, it strikes me that these instruments likely capture frailty. And so is there a way to put them to work and assist with the plethora of instruments that are being worked on, looking strictly at frailty?
I think the answer is absolutely yes. They are being put to work in the sectors that they're used in, but what I see as the opportunity for more sharing between sectors. So I do think it's important for people in acute care and primary care to have assessment tools that they would use in those settings, but they should also be recipients of assessments done in other settings. So we did a very simple demonstration project where we shared RI home care assessments with primary care docs, and we targeted falls as an area of intervention. And what we did is we gave a little pamphlet for home care clients who had fallen to talk about the importance of falls for them and told them, speak to your family doctor. We sent the summary to the family doctor with the indication that falls had happened. In the intervention regions, we found about a 20% reduction in actual falls in a 6-month follow-up compared to the non-intervention region. And that's about as simple an intervention as you can think of, just sharing information between settings. So it's more cost-effective, and it's more in the interest of the person for people to be working together in sharing information.
And Jana.
Just a follow-up question from the discussion before. You know, I agree that frailty is probably a good thing to sort of initiate a conversation about care planning. And, you know, the example of the renal example, you know, someone with end-stage renal disease and they're frail, making decisions about dialysis or not. The part I struggle with clinically is people, when they're well, make these care plans and decisions. And we see this often with, I think, the renal patients classically, because they're going to have renal disease for a few years, is when they become acutely unwell and the family becomes panicky, the patient becomes panicky, they end up in our acute care system. And the plan, if we don't support them, which is very hard to do in the community with the current setup, is they end up actually going down a path that they hadn't initially wanted to. Because it's hard, I think it's really hard for them to understand what even if you coach them and talk to them, they don't really understand what they're going to get down the road, what's going to happen, how it's going to feel, and the anxiety with it, and the pain and the suffering and all that if we don't support them. So I'm wondering your thoughts, like particularly wondering what you're doing in Nova Scotia around that when you have these decisions, because that, I know Alberta's doing that too around, there's lots of evidence, frail seniors probably do better if they don't go on dialysis, but you have to support them or they end up in acute care and end up on dialysis.
So I'll ask Sean first to respond to that, and then Paige.
Well, Jana, I think we come very late to that discussion, right? And often when intensive care becomes involved, there has been that maybe change in care plan whereby it was laid out before, where discussion was had and patient preferences were maybe articulated to the crossroads of an acute deterioration to the point where some escalation in life support is needed. And that's where we often come. And it's not advantageous necessarily for us to come at that point and start to re-engage in this entire process. Maybe having some perspective on where patients will go from critical care as they go forward. But the point being is that we don't know the patient necessarily. We don't have a long-term relationship with them. We don't know any of their family members or surrogate decision makers. And while we have relationship with the providers, we don't have any interaction there. So I think it's not ideal that we are involved at that phase. I think a lot of the work has to be done long before they have that acute deterioration. It's one of the challenges that I think we as intensivists often are very frustrated with and challenged with as well. So it's my only real comment.
So last word to Paige.
So I think, Jana, you've really hit on one of the major challenges to advanced care planning, and that is, and I'm going to say something really unpopular here, I think by and large, advanced care planning programs offer the illusion of more control than they can feasibly deliver. And I think there's been this initial push to say, okay, well, what we've got to do is got to move this upstream. We've got to move it upstream. We don't want to do it in the ICU. We don't want to do it in the emergency department. We don't want to do it in acute care. Let's make sure everyone has an advanced care plan that they draw up while they're well and healthy. And as you've just said, that the challenge with that is that oftentimes these advanced care plans are made in isolation. Someone sits down in their kitchen and writes out, I don't ever want to go to long-term care, right? And then 10 years later, health has totally changed, and a substitute decision maker and the healthcare providers are then acting on what can be a decision or a directive that's very, very much out of context. And I think that's why, one of the central thrusts of the PATH program is that we have to be able to respond to the health crisis. There has to be a healthcare provider there during the health crisis, either by phone or in person, who can help navigate through that decision, who can take into account what are, the variables and the factors in that person's current state of health that are going to inform what the outcome is going to look like. Because inevitably, from mild frailty to very severe frailty, what is right one day may not be the right thing the next. And so, in terms of advocacy, you need another person who knows your health history almost as well as you do, who can help advocate for you, but you also need a healthcare provider who can help you navigate through that really difficult process. I think we're kidding ourselves if we think we can make all of these decisions in advance. I don't think that's going to result in better care by and large.
So on your behalf, I'll thank the panelists, ask you to join me in thanking them, and then I know John wants to speak for a few moments at the end. So thank you so much.